Welcome back to our video in Chapter 13. We're going to move away from biological therapies, such as drug therapy, and look at psychotherapy, which is a non-medical process, helping people to recognize and overcome some of their difficulties. So this may be something sitting in a room talking about the problems together. It may be assigning homework or activities or journaling. It may be a deep exploration of the unconscious mind, or simply a counter-conditioning of bad behaviors. The point of these, and there are many types, is that it's non-medical, meaning that we're not trying to change the biology, at least not overtly. The first example we'll talk about is psychodynamic therapies, and that comes from Sigmund Freud. These are still used today, though some of Freud's earlier beliefs have sort of been moved away. That's why you'll hear things like neo-Freudian belief system. But the idea that Freud hit upon was that a person's behavior is based mostly on their unconscious mind. The idea that we have these impulses and drives that we're not even aware of, but move us and push us in certain directions. And so he believed the therapist's job was to explore the unconscious mind. And that may take extensive interpretation, meaning you may have to listen to the words or listen to the actions, but interpret the truth behind those words. Psychodynamic theory also places a strong emphasis on early childhood. Perhaps those early childhood experiences is what led to those current impulses and drives that you have. As far as psychoanalysis goes, the idea is to try to look at the unconscious mind to unravel just how and why you're doing what you're doing. And as I said, Freud believed that it's our job as therapists to probe, to ask questions, and to analyze what's on the surface to try to find some sort of deeper meaning. Freud did focus more on sex and sexual development, hence his psychosexual theories, but as I said previously, that's sort of been discarded for more robust analysis. There are some things that Freud sort of brought to the table that are still used today. For example, you might remember us talking about free association. The idea that you let a client or patient talk about whatever they want with little guidance from the therapist. You may prompt them or push them to continue, but ultimately you're letting them decide the path of their discussion. The idea being what's important to them will come out, and it's possible that that may provide some level of catharsis. Freud used that term to refer to that sort of emotional release we have when we finally let go of something, even if it's just saying it out loud and admitting that there's a problem that can cause some sort of relief. Freud also was big on interpretation, which I've made reference to before. The idea that as a therapist, you need to look for hidden symbology in what people say. So I may be talking about problems that I'm having at work, and the therapist may believe that those problems extend to something deeper, perhaps family problems, or perhaps there's an issue that I'm avoiding talking about. You might remember from our chapter on why we sleep, the question of why we dream came up, and we said Freud believed we dreamt because our unconscious mind was processing information that we were not aware of, and now we're beginning to see emphasis on that information. He said that dreams contain both manifest content, which is the explicit content. So if you say you dream about failing tests constantly, they would say the manifest content is you're scared of failing out of school. But Freud also believed, since interpretation was big in his idea, that dreams had latent content, a metaphor or an under-the-surface message. So you might be dreaming a lot about drowning, and Freud would say, well, that's actually your feelings about becoming a new parent since you're pregnant. And so, once again, we talk about relying heavily on interpretation. Now, Freud believed that if you enter a genuine relationship with your client or patient, it's not surprising if they begin to experience what's called transference, the idea that they will see you or project on you the feelings that they wish they had for other people. So let's say, for example, my husband is always late and never listens and doesn't pay attention to me, and those are creating problems. But my therapist is listening to me and paying attention to me. So my therapist kind of becomes the version of the person that I want. And Freud thought you could use that as a therapeutic model, but you can see how that might cross over into some unethical boundaries as well. Freud also thought that clients who resist you, maybe they argue or they come late, things like that, they're actually showing you a defense mechanism. They're trying to avoid dealing with the problems, and it's up to a therapist to deal with those issues. So in terms of psychoanalysis, the idea, once again, is typically for unconscious and early childhood. But I told you there's this thing called Neo-Freudian, the idea that they took some of Freud's theories but changed some of the emphasis. And I've put some examples here. A modern therapist who's trained in the psychoanalysis school, the psychodynamic school, is still going to focus on the conscious mind. It's not totally unconscious. They're not just going to focus on early childhood. We'll look at current relationships. As I said, less emphasis on sex. There's the old idea that we get from Freud's model where someone lies on a couch and talks about their problems. Rarely does that happen. Typically, you're sitting together in an office. And we do find that whereas Freud saw his patients several times a week, the modern therapy model, and this is not just psychodynamic, this is most therapy, is traditionally once a week. Sometimes less if the problem is not as severe. Now, another example of a type of therapy or a group of therapies is humanistic. So this is a different group than psychodynamic therapies. And if you look at some of the points I made here, look at their emphasis. Humanistic psychologists believe, or at least explore the notion of being the best you can be, gaining control of your life and making those changes. So humanistic therapies don't focus on the past, they focus on the present. Let's focus on what you're doing right now. Let's focus not on the unconscious, but what you're actually thinking about, what you want, what you feel. The idea that you have the capacity for change, you can be the instrument of your own change. A good example of this is client-centered therapy, which was created by Carl Rogers. He believed that the goal of a therapist is not to unlock those deep unconscious secrets, but instead to just live in this moment, to find out now, genuinely, how does this person feel? Why does this person feel this way? An example of a technique Carl Rogers would have used is something you've probably seen on television, where it's called reflective speech. The client is describing something, and the therapist sort of reflects back their own emotions to let them know, I'm listening and I understand that this is what you're going through. Please continue. So a woman, might be talking about how her husband died and how terrible that process is, and the therapist says, you must be really angry, you must be really sad at that. Just sort of giving them back what they're offering. Now, Carl Rogers did believe that patients, let's not even use the word patients, he believed that clients needed to have an authentic relationship with their therapist. What that means is that instead of treating it like the medical model of I'm the doctor, you're the patient, as I wrote, he didn't even like the word patient. He used the word client and then even just went to using the word person. He believed that we as the therapist have to have genuine relationship with this person. I don't mean be their friend outside of the session or hang out with them, but the idea that you must emotionally empathize with them. And so he came up with what he called 3 elements for growth that all clients or persons need to change. The first, unconditional positive regard. That means that your job as a therapist is not to judge, it's to provide a supporting environment despite what the person's done. So you can disapprove of what the client has done, but not the person themselves. That's that third point, genuineness. The idea that you can be honest and you can say that, I don't like what you're doing, but I still think you're a good person. So that's that sort of unconditional positive regard. And finally, empathy, that idea of, understanding what they're going through. He believed a good therapist should be able to say, I can understand why you would feel that way or act that way. Again, even if you don't agree with that behavior, you can kind of understand it. Now, a third class of therapies is quite different, and that's behavioral therapies. You've actually learned about these in our Chapter 5 when we looked at behaviorism. So we looked at classical conditioning, operant conditioning. Behaviorists believe that it doesn't matter why you're sad or why you're angry. They believe it's the behavior that's the problem. It's the way you act that's the problem. So they strive to condition away those poor behaviors without focusing on why they're there. So that might be using classical conditioning, which is, again, something we've already learned in Chapter 5. A good example of classical conditioning would be systematic desensitization. The idea that I'm going to take something that already makes you anxious and I'm going to pair it with something that doesn't make you anxious. So, we take the conditioned stimulus and the neutral stimulus, and we put those two together. Or if you look at operant conditioning, which you might remember was reward and punishment, maybe I will reinforce the behaviors, the good behaviors, punish the bad behaviors. Or if you look at applied behavioral analysis, which is very common with autistic individuals, the idea isn't even punishment. The idea is, well, let's look at the bad behaviors and let's ask ourselves what's being reinforced here. And I will not reinforce them for that bad behavior, and instead I will give them that reinforcement they want when they behave accordingly. Now, cognitive therapies, fourth on our group, focuses on how people think. So the idea is the therapist's goal is to counteract or to somehow try to change the way this client is thinking about themselves or the world, and that will change the behavior. So if you think about things like eating disorders, right? I think I'm fat. I think I'm ugly. I think I need to starve myself. If we can change the thoughts, then maybe we can change that destructive behavior. Albert Ellis was one of the pioneers in this, and he created what he called rational emotive behavioral therapy, which is often just called REBT. It's actually kind of interesting because Ellis, though he's not saying don't be empathetic, he was quite confrontational, and he believed the therapist should be confrontational. He believed that the job of the therapist is, since it's bad thinking that's causing bad behavior, to call people on their bad thinking, to point out when their thinking is illogical. He called this idea clients masturbating, as in, I must have certain things. He believed that clients have these three demands that are just illogical, and I put them up here. I must perform well and win approval of everyone. I must be treated kindly and fairly by everybody. I must not have a frustrating life. It must always be enjoyable. And he said, these are unobtainable goals, and they're causing a lot of stress and anxiety. And if you can sort of tackle the logic problems here and find a more rational version of these issues, then you can help that person deal with their anxiety. Now, there is a sort of a combination of both cognitive and behavioral therapies. And so I just wanted to make a quick example of this. Albert Bandura, who you might remember, did the Bobo the Clown study. He studied observational learning. He talked about a concept of self-efficacy. If you can change the way a person thinks about their responsibility, their ability to master their own actions in their world, then that actually will change their behavior as well. And so you can sort of teach them to modify their behavior. So you're changing the thoughts and you're changing the actions at the same time. Kind of two different problems. A good example of that would be sort of testing through, not counter-conditioning, but testing through irrational thoughts. So I gave you an example here of panic disorder. Let's say someone is absolutely certain that this terrible thing will happen, whether it's something bad will happen if I don't touch all the walls, or if I take this test I will fail and it'll be the end of the world. And so what someone might do is to say, okay, let's do it. I'm going to show you that this doesn't happen. And so you sort of expose them little by little and show them how their thinking is faulty. This is no substitution for certain medical interventions, and that's why I wanted to bring up schizophrenia. You remember from our last video, it is most prominently treated and most effectively treated with psycho or antipsychotic drugs, but cognitive and behavioral therapy greatly helps reduce symptoms and helps those patients manage those symptoms. All right, we're going to stop there. When we come back, we're going to look at a little bit of therapy integration and look at sort of what the research says about types of therapies as we wrap up this chapter. See you then.